My name is Dizon. I'm a medical oncologist. I direct the pelvic malignancies program at Brown University Health. I think just in general, people who are members of what I term the sexual and gender minoritized communities, they come into cancer with their own healthcare experiences, and oftentimes it is a mix of bad as well as not so bad experiences, all the way from not being treated in a comfortable environment to frank hostility. So that carries over to when someone is diagnosed with cancer because, especially in gynecological cancers, the treatment is what's called multidisciplinary, which means you're in contact with multiple physicians over the course of your cancer journey. And for people who are in the sex and gender minoritized communities, it means that there's always a risk that you will need to come out continuously. And I just heard a term about this called the out fatigue syndrome, which is where you're just tired of having to declare your sexuality so that people will treat you how you deserve to be treated. And it manifests by, when two women are in a room and the assumption is they're sisters, or one's a mom and one's a daughter, or, just this sort of lack of recognition that two people of the same sex might actually be romantic partners or life partners. And so that's a constant struggle. And you could have the most welcoming, accessible physician, but if the people who are checking you in are not recognizing relationships, or in the case of, say, a trans person, referring to them by the name is assigned to them at birth, sort of what's called a dead name, then that's a dehumanizing experience. And I think it is sometimes worse for people who are trans who go on to develop gynecologic malignancies like ovarian cancer, to be sitting in a room filled with women as a trans man. That takes courage to sit there and to claim the care that you deserve. One of my earliest experiences really was taking care of a trans man with ovarian cancer and walking to the room and assuming that his wife was the one with ovarian cancer and being very quickly corrected. It was a very humbling experience. It was a crash course on being aware that you cannot judge a book by its cover, that your assumptions may or may not be correct. And it is always worthwhile to get to know somebody who you are treating. And that begins by providing everybody the same set of questions so you can understand who this person is more fully beyond the cancer. And I think that's the thing that I would like all of my colleagues to remember, that even the person who doesn't look gay may be gay, that we all do not wear our sexuality on our sleeves. And it does behoove us to treat everyone similarly. And that begins by understanding who that person is, including who that person loves and how that person views themselves. I mean, I think the foundation of everything we do is trust. And I think for all of us, we require that level of trust when something as serious as cancer enters into our lives, because every decision carries weight, especially if, say, someone is dealing with advanced or metastatic or even recurrent disease. There is the sense that my life is in your hands. I can only trust what you tell me are my options. And that leap of faith has to be grounded in a relationship that is open and, yeah, trusting. I think for people who have been diagnosed with an ovarian cancer from the sex and gender minoritized communities, it is well within your rights not to feel uncomfortable in your care relationship. You might have to teach your oncologist about how to adapt, how to interact with the LGBT community. But I can also tell you that the research shows that oncologists are willing, ready, and interested in becoming more culturally aware of how to deal with and interact with the LGBTQ community. So you might find yourself as someone who is seeking care, but finds themselves also in a role of a teacher and, providing really good longitudinal instruction on how to become a better doc with an awareness of the SGM communities. The one thing that cancer organizations and advocacy groups can do is help us break this association of cancer with a gender. And we always think of women with ovarian cancer or women with cervical cancer, women with breast cancer, but we do know that men develop breast cancer, and we know that trans people develop reproductive cancers as well. I'm part of a group through the American Society of Clinical Oncology, really pushing this notion that cancer does not have a gender. Cancer arises from an organ. So when we talk about ovarian cancer, when we come together to demand better for people with ovarian cancer, we are talking about people, not women solely or restricted to women with ovarian cancer. And that can be seen as, a political statement, but in reality, it's an inclusive statement when we say, for anyone diagnosed with ovarian cancer, or when we say anyone born with ovaries can get ovarian cancer, what you're doing is including more people who see themselves in those statements. My favorite part of my work continues to be the elements of patient care. I've never stopped seeing people with cancer. Those are relationships that, sometimes are very short, more often than not expand and extend through years. And really getting to know somebody as a person is just a very fulfilling part of my job.